Dr. Sabrina Siegel with the Neuroscience Education Institute, and twice a month, I sit down with a renowned mental health care expert to discuss breakthroughs and best practices for treating patients with mental illness. In this episode of the NEI podcast, titled Somewhere Over the Rainbow, Addressing Mental Health Care in the LGBTQ Community, I have the privilege of interviewing Dr. Rhonda Schwindt, Associate Professor and Director of the Psychiatric-Mental Health Nurse Practitioner Program at George Washington University. She is also a practicing psychiatric nurse practitioner. I also have the privilege of interviewing Dr. Stephen Forsell, who is founder, director of the LGBT Health Policy and Practice Graduate Certificate Program at the George Washington University. And he is also an assistant professor in psychology at George Washington University. Welcome, Dr. Schwindt and Dr. Forsell.
Thank you.
Let's begin by exploring gender identities. What is gender identity?
Well, first, I think it's important to distinguish gender from sex. Sex relates to one's physical body at the time of birth, so your biological makeup as regards your sex chromosomes and sexual organs. Typically, live births occur as either male or female, although there are exceptions to that, which we can talk about a little bit later. But gender is a psychological construct, so it's your sense of maleness or femaleness. So specifically, gender identity is your own unique, personal, individual experience of gender, and including how you choose to label it. So this could be either male or female, or something in between, or neither, or both.
Interesting. Thank you for explaining that. How many genders are there, and what do they mean? What does it mean to be transgender? And what about non-binary? I know that's kind of a bunch of questions in one.
Yeah, excellent questions all. Quite often, gender identity matches one's sex. So that would include, say, biological male, someone who's assigned male at birth, which is the phraseology we use now. That's someone whose gender identity is male and it matches their biological sex assigned at birth. Now, it would also be the case for, say, someone assigned female at birth who identifies as female. In both of those cases, these are what we call cisgender individuals, and that's the most commonly occurring scenario. And a lot of people have heard the term cisgender, but it's important to point out this is not just a recently invented term. The prefixes of cis and trans are actually used in science and other areas. So cis as a prefix, a Latin prefix, means on this side of, which of course is the opposite of trans, which means on the other side of. So in chemistry, for instance, there are cis isomers and trans isomers. So cisgender means someone whose gender matches and is on the same side as their sex. So logically, transgender implies that a situation in where an individual's gender does not match or is on the opposite side of their sex. So someone whose gender identity is male, but who was assigned female at birth would be transgender. And these individuals typically use labels such as transgender male, trans male, or sometimes trans masculine to define themselves. The identities usually match how they identify, not what their biological sex is. And the same would be the case, obviously, for someone whose gender identity is female, but who was assigned male at birth. They would typically identify as transgender women, trans feminine. Now, if you're counting, we have essentially 4 different gender identities here. We've got cisgender women, cisgender men, transgender women, and transgender men. But all 4 of these categories, the second part of your question gets to the point of non-binary. All 4 of these categories fall into a binary, an assumption that there are just 2 genders, male and female, and that our physical bodies either match our genders at birth, cisgender, or they don't. So this has kind of been a working assumption for decades in modern medicine and really in centuries in most of Western culture. The medical community, by the way, when talking about transgender, has been aware of transgender phenomenon since really in the early 20th century. but it's always been in this either or binary fashion.
Mhm.
We used to use the term transsexual. That was a commonly used term, which kind of implied that there was a destination, that someone was going to make a transition, a literal physical transition, hormonally and surgically from male to female or female to male. And those procedures actually have been done quite a long time. The first recorded hormonal and surgical procedures used to transition, in this case from male to female, happened in 1930 in Germany through a series
Wow.
of procedures. Yeah, it's been going on quite a while. Back then, we used the term sex change operation, which is quite an antiquated term now. But now the preferred terminology is either sex reassignment surgery, or the community tends to prefer gender affirmation procedures or gender affirmation surgery. But more recently, as you implied in your question, social sciences have come to realize that gender is not necessarily on a binary. Many people have reported their experience of gender, and their gender identity is not fully male or fully female. They may, for instance, report a lived experience of feeling both male and female, or neither. So these are individuals who would fall into what we would call the gender non-binary. But they don't necessarily call themselves gender non-binary. Some other terms are in use out there, such as genderqueer or polygender. And so there's really an infinite number of labels that can be applied. Now, interestingly, I mentioned at the top how live births biologically are mostly exclusively male or female. And so this sort of gender identity actually parallels biological sex, in the fact that biological sex is not entirely binary either. In about 1.5% to 2% of live births, the births are not exclusively biologically male or female, so they may be born with ambiguous genitalia or other conditions. So sex chromosomal conditions such as Klinefelter syndrome, where there's two X's and a Y, or Turner syndrome, where there's one X, or non-chromosomal things such as congenital adrenal hyperplasia or androgen insensitivity syndrome, all result in not typically male or exclusively male or female. So the gender identity actually parallels what goes on biologically.
Wow, that's so interesting. What are some healthcare disparities for LGBTQ people? Why do you think that these health disparities exist?
Yeah, well, there are both obviously medical health disparities as well as mental health disparities. The medical disparities that we're mostly aware of include things such as higher rates of certain types of cancers. So cervical and breast cancer, for instance, in lesbian women, have been observed to be higher than in heterosexual women. We also tend to see higher rates of eating disorders in gay men and lesbian women, such as bulimia and obesity. And of course, we know that HIV disproportionately affects gay men. But I think it's the mental health disparities that are the most noteworthy and concerning, and namely depression and anxiety. And the causes of these mental health problems are in some ways obvious and clear. Harassment, discrimination, family rejection, they all result in isolation and contribute very strongly to the mental health problems we see. And I know Dr. Schwindt will probably talk a little bit more about that. But I think it may be actually the fact that these effects are so clear, we probably don't pay enough attention to them. So to the second part of your question, like why these disparities exist, I think we can largely look to disparities that we also observe in risk behaviors, such as smoking, substance use, that we've seen to be higher in LGBTQ people. And these behaviors, I think, are when we know they clearly drive cancer and heart disease and other illnesses. But I think you can also say that much of what drives these risk behaviors is that discrimination, harassment, et cetera, where, for which smoking, alcohol, and substance use are, they serve as coping mechanisms. Not healthy coping mechanisms, but coping mechanisms nonetheless.
Wow. Yeah. That actually turns us to our next question, which is, what are the greatest mental health disparities in this population? I know you touched a little bit on that, but Dr. Schwindt, could you share a little bit more with us on this?
Well, I'm glad you asked that question, because I think it's one of the most important topics when we think about the LGBTQ or the sexual and gender minority population, because for the longest time in the psychiatry profession, we liked to take individuals who are sexual and gender minorities and place them in boxes and then considered them to be disordered. In our diagnostic manual, it wasn't until just really a few years ago that we stopped calling a different gender identity, something that did not fall within that female-male binary, as a disorder, when in fact, being a sexual gender minority is not a psychological condition. It is not a psychiatry problem. And we also know with some of the mental health disparities that we have to talk about where do they actually come from. So before we start really going into what they are, it's really important to know, why do individuals who are members of the LGBTQ community have more disparities? And we know one of the primary reasons is access to care. And even when people who are members of the gender and sexual minority community actually access care, they can't find providers who are well educated, who are well informed
Right.
about the needs of the LGBTQ community.
Mm-hmm.
And then that kind of snowballs, right? So they not only don't have access, but then when they get access, or they struggle to find providers who really are fully accepting and affirming.
Right. Right.
And then, even if that happens, they still have to go somewhere and check in, right? They still have to interact with other people to get to that provider. And it's really common for them to experience stigmatizing and discriminatory experiences. They're exposed to that when they're trying to seek the care. And so when you put all of that together, it really makes perfect sense why in the LGBTQ community we have more depression, more anxiety, more likely to be diagnosed with PTSD, more likely to use substances. And also, I think it's really, really important to keep in mind, too, is that we have a really sad history of subjecting our LGBTQ members of our community to the conversion therapy, which still is not illegal in many states in this country, both identity conversion therapy as well as sexual orientation conversion therapy. And many of our patients have been subjected to that. And so again, how could you not develop post-traumatic stress disorder related to that, or or experience some depression and anxiety? And when we talk about suicide here in a little bit, and what are some of the unique factors in this population that make the suicide rate so much higher, we can kind of follow up a little bit more on that specific reason.
Okay. I believe that there is published research demonstrating that gender affirming surgery is associated with reduced mental health problems. Why do you think that this is the case?
Again, that's a really great question, and I'm glad you asked it. When I speak on this topic, it's probably one of the most common questions that come up. When someone makes a decision to have a gender affirming procedure, and in this case, we're talking specifically about a surgery, if they want that to be a part of their gender identity, and they're able to then finally achieve that, what that really ends up meaning is that now that physical part of them matches their internal sense of who they are. And so it's a huge affirmation of the sense of them as an individual person.
Right.
Now, not everybody wants to do gender affirming surgery or want to have any gender affirming procedures. That's a very individual decision. But we do know that when people are able to access and have those procedures and surgeries that they desire, that their mental and physical health dramatically improve.
Wow. Wow. Yeah, I think that's saying a lot. It's pretty astonishing when you think about that. And just how the physical health is connected with the mental health, and how I think sometimes we forget what a reciprocal relationship that is. So that's pretty amazing. What has been particularly challenging for the transgender population during the COVID-19 pandemic?
Well, I think first, I think it's important to note that, well, obviously COVID is complicated treatment for everybody, but it's even more so for all members of the LGBTQ community, not just trans. And I think we should also start with the understanding that transgender experience with medical community is especially bad. It has been historically negative. For instance, the most recent large sample size survey that was published by the National Center for Transgender Equality in 2015 showed that more than a third of people surveyed, all transgender, had a negative experience with healthcare in the previous year. So these are things like being refused treatment, verbally harassed, or even physically or sexually assaulted in the actual care facility, or even having to teach their provider about transgender people in order to get, the appropriate care. And sometimes the maltreatment is a little less overt, but still very problematic, so being misgendered by the intake nurse or by frontline staff, or subtle microaggressions like nasty looks or comments from the staff. But and it's important to note that these problems were even worse for persons of color and people with disabilities. In addition, I think trans people quite often have more interactions with medical professionals in general as a function of their medical transitioning, if they are transitioning. So there may actually be more opportunities for that to happen in the first place. Now, when you add COVID to the mix, you can see how these things amplify. The key thing is that medical resources are very strained. A lot of ERs and other care facilities have a lot of resources diverted. So transitional care can be delayed or declined in these situations, which, is really stressful for many people in transition. Right. So the barriers to getting quality care, which are already high, become even more challenging. And I think probably the biggest effect is really the effect of the isolation that pandemic has brought with it. Being isolated is tough on everyone, but it really is the toughest on those who are already experiencing depression and anxiety, isolation, and trans people we know are particularly vulnerable in that way.
Right. We know that the LGBTQ youth have higher rates of suicide than the general population. And could you shed some light onto why this is happening and what can be done to prevent it?
Yeah, well, we've obviously, we've talked about a little bit about discrimination and harassment, which occurs. And this, of course, very, very contributory to anxiety and depression and suicidal ideation, attempted suicide, and the evidence shows now completed suicide. In terms of trying to deal with that problem, obviously, the more we can do to mitigate the experiences of discrimination and harassment young LGBTQ people have, the better. So going at the harassers, trying to train public education interventions, for instance, such as cultural competency training or sensitivity training in schools and in workplaces and things like that, are all very important. I particularly think that working with families on reducing rejection is also very critical. A lot of studies have shown that if families are supportive, and the immediate response by a lot of families is negative, and that's not necessarily to be not expected. It is kind of expected, but a lot of families turn it around after that. So the more that we can do to promote acceptance by these families, the better off they're going to be. So a child will have a home base of support. Right. And I also think we can do a better job at training mental health care providers in general, about the unique needs of the population. So training care providers to best serve their clients. And that actually is the mission of the program that I run at GW in LGBT health policy and practice. We train providers, mental health, and as well as medical care providers. But
that's great.
Thank you. But for LGBTQ people themselves, though, I think there's a lot of developing evidence-based approaches that we can use to really, not just in the one-on-one psychotherapeutic environment, but that we can do on a broader scale to increase resiliency skills and to foster social support, or their ability to seek and sustain social support that are having a positive impact. So those are all ways I think that we can help reduce this problem with suicide.
Those are such important points, Steve. And to build upon that, there was a large study that came out in 2019 that was looking specifically at suicide in the gender diverse community and what factors contributed to the higher rate of suicide that were the same for the general population, and what were those factors that were unique to our gender diverse youth. And even to backtrack a little bit, I think it's really important to even think about this suicide rate, So in the gender diverse community, the suicide rate, everybody estimates it slightly differently. So I'm just going to average it out and say 40%. In the general population, it's under 4%. That should keep people up at night. That is just mind-boggling that there is such a huge disparity in terms of mental health, to the point that our gender minority youth and adults try to harm themselves when compared to the general population. And some of the things that they found out is what you mentioned, Steve, very important. Family support is absolutely right up there. Also, that discrimination and mistreatment that you talked about. Also, the fact that and I'm talking specifically now about our gender diverse folks, really on a daily basis have to face the threat of violence against their person. And
Right.
so what we know is that our gender diverse people, particularly of color, are more likely to be physically harmed in some way. And that's unique risk factor for suicide that we've really got to try and we need to address. Now, the most important and interesting, I should say, not more important, but one of the more interesting facts that also came out when they analyzed this data was that those individuals who identify as gender diverse, whether it's transgender or non-binary or genderqueer, were less likely to commit suicide if they had not disclosed that they were gender diverse. So if they, in their own community, whether it was family, friends, school, work, if they did not tell people they were gender diverse, they were less likely to attempt suicide. And when I first started studying that, I had to take a long time to really think about that. But then you realize, well, yes, that makes sense because they haven't put themselves out there, right? They may be less likely to have that stigma and those discriminatory experiences. They're trying to protect themselves against those violent acts because we know that people who are different are treated differently and not in a positive way. And also rejection from religious communities. I think that has to be said. When our youth have the support and our adults of a religious community that fully includes them, it's not tolerance, right? It's acceptance. They're less likely to harm themselves. And so we, as Steve mentioned and did a beautiful job of mentioning, we have a lot of work to do as mental health providers. And each time I see one of my gender diverse patients or consumers, when they leave, I think, oh my gosh, about 50% of them are going to try to harm themselves if I follow the national trends.
Right.
And that's scary. That's really scary that we haven't done a better job with that.
Thank you for sharing all of that with us. We know, and this touches a lot on what we've just been talking about, but that there is so much stigma that surrounds the LGBTQ community. Dr. Forcell, can you comment a little bit more on this?
Yeah, well, yes, absolutely. And the stigma, we've made a lot of gains, obviously. We're all aware of policy changes that have been made over the past many years that have been very positive. And as much progress as we have made, there is still a lot of existing stigma. And it's maybe tempting to think, well, things are all better now. It's, not really the case. There's still a lot of discrimination, harassment, and stigma associated with identifying as lesbian or gay or bisexual or gender diverse, transgender. And a lot of this is geographically specific. There are regions of the country, particularly more rural regions of the country or places where religious orientation is, which Rhonda mentioned very rightly so, that where the religious traditions are perhaps more rejecting and there's less progressive attitudes, but more importantly, where there are fewer resources for young LGBTQ people. So the stigma has a huge impact. And Rhonda and I were discussing before we started here that there's a phenomenon known as the minority stress model, or a theory called the minority stress model, where it's recently developed, quite recently developed, but it seems quite obvious. And we've got large data sets now where we can really examine this empirically and methodologically quite rigorously. And basically, the take-home message is that independent of all many other sorts of factors, income level or neighborhood you live in or education, things that may contribute to bad health outcomes mentally or physically. It's the actual weight of carrying one's sexual orientation being different or gender identity being different, gender diverse, that has an impact independent of all those other factors. And I think Rhonda really got to it quite clearly there when she mentioned that gender diverse people who have not yet disclosed this haven't really experienced it in the real world. Once they're out there to be observed and treated by society, that they probably will start to experience this. And of course, that can be very, very disruptive and problematic. And some LGBTQ kids growing up, some can hide better than others. Some, are better able to sort of mask their sexual orientation, but others are not. Others are feminine acting boys or masculine girls get teased. And that sort of, like Rhonda said earlier, going about your business in the world with a constant fear I might get beaten up, I might get harassed or worse, is a constant thing to carry with you. And this, of course, applies to racial and ethnic minorities as well. There's a lot going on that we know can point to now about the experience of Black people in this country who carry the minority stress model would also impact them. So it's not surprising to me, based on the findings of the tests of this model, that we're seeing negative health outcomes, physical and mental health outcomes for any person of a discriminated or minority status.
Right. Absolutely. This gets me thinking about what can be done at this point. And my questions are going to turn to, I think, more of a positive outlook in terms of spreading the most helpful information for clinicians to be able to better treat this population. What are some specialized training areas that mental health providers could benefit from so that they can better help treat patients in the LGBTQ community?
I keep saying this. All of these questions really hit the most important aspects of the LGBT community. And then, as you said, kind of shifting the focus now on what can we do as providers. And Steve, at any time, please feel free to jump in on this. I think one of the things that we must take a responsibility for is to recognize that there are unique healthcare needs of members of the LGBT community. And as whether it's a mental health provider like myself and Steve or in another specialty, it's our responsibility to learn about that. It's not the responsibility of our LGBTQ patients to teach us. And if you don't mind, I'll tell you just a really quick story. I had a patient say to me that he went to the dentist recently to get his teeth cleaned. And at the registration desk, he said, "My name has changed." And he had changed his name, and he wanted his documents now to all match up. And as soon as he said it, he said he regretted it because the rest of the visit was all about his gender identity. And he said everybody from the person at the front desk to the dentist to the dental hygienist wanted to just talk to him and ask him all these kinds of questions and also just prove to him about how uber affirmative they were. And he said, all I wanted was to get my teeth cleaned. It wasn't my job to teach them. I don't want to be the token gender diverse person. I want to be able to get my teeth cleaned just like anybody else. So my point to that is we have to educate ourselves about basic terminology, about what is the difference between sexual orientation and gender identity. What are some of the unique health needs? What do people experience that are members of gender and minority groups? We also, I think, and Steve, you alluded to this early on when you mentioned cultural competence, we also have to be willing to explore our own unconscious biases. We need to undergo cultural diversity training, and we need to be willing to take a step back and be self-reflective and recognize how are we engaging in that bias, and then what can we do to change it? Because everybody does. It's a matter of recognizing and then taking positive steps forward. So I think that's one of the first places that we have to start, and that's take responsibility as a provider first.
Yeah, that's great. And actually, I love this story about the dentist because that's very typical. And it's great that people want to show they're positive and affirming, but trans people and gender diverse people really are sick of being put on display. And, the things that are important to remember is asking questions. Some trans people, sometimes they get these very probing and personal and, quite frankly, not medically necessary questions. And that really does make people feel sort of objectified. I don't think that's very good. I'll add one other thing to it. And Rhonda's point was very good. We need to make sure that we educate ourselves and check our own biases, check our own privilege. But the gist of my program is we as professionals are in a position who are trained to understand these issues are in a position to, and I feel have obligation to train our peers. The students in my program, for instance, all do capstone projects, and they're all providers of one stripe or another, mental health care. We got medicine and nursing and social workers and educators. And their capstone projects quite often are trainings, so professional trainings for their colleagues to help make them more aware of what they need to do to improve the quality of their care. And we get a lot of students now coming from very rural parts of the country who, it's easy and we're located in Washington, D.C., one of the most gay-friendly cities and on the most gay-friendly coast, et cetera. That's all good and fine. But there are plenty of communities where there are isolated LGBTQ people or professionals who are practicing that can help educate their peers. And they do. So the projects they do in my program are quite often working with, one recently is a middle school counselor. He developed a training program and piloted it and did an evaluation of it on how to improve that. So that's kind of all on us to help our peers improve the quality of their care. And I think that's important. That's, I think, how we're going to affect change. And I've really found that the big difference between now and 25, 30 years ago now is people in communities who they don't identify as LGBTQ, they are heterosexual and cisgender, but as opposed to being antagonistic or skeptical, I find a lot of them more so want to do the right thing. They want to learn, they want to help. And they're really just looking for someone to come in and tell them, what they have these questions, what's appropriate for me to ask. If someone says, like Rhonda said, the patient, they've changed their gender or their name and their gender with it. What's the right way for me to handle that? How do I talk about this? Those are all things that we can and should do as professionals to educate our professional peers.
Right. Absolutely. And that turns me to my next question, really, which is how can clinicians help recognize and treat the mental health needs of patients in the LGBTQ community if they don't have advanced or specialized training for this population? What sort of first steps would you share with them?
Well, the good news is that there are quite a few resources out there. I think one of the first places to go is the National LGBTQIA Health Center, Education Center, that's sponsored by Fenway Health. So you literally can just Google National Education Center for LGBTQA and it will pop up. And it has all kinds of archived webinars, articles, pamphlets that it all can be downloaded for free that will help organizations begin to set up affirming environment for their patients. It has everything ranging from what do you need to do if you're a primary care provider to what are the things that you can do if you're a pharmacist. Now, the Human Rights Campaign is wonderful for a variety of reasons, but they also have resources there. They have a wonderful guide, for example, on pharmacy staff. And that's a real issue, particularly if you think about our gender diverse people. They go in to pick up a prescription. And perhaps they're a transgender male, identify as transgender male, and they are receiving masculizing hormone treatment with testosterone. But their name, right, may not match in that pharmacist's mind about what that individual looks like. So in
Mm.
front of everybody, because let's face it, there's no pharmacy out there that's really private, starts asking, why do they need testosterone?
Oh, wow.
And it can be very humiliating, even thinking about those things. And so the HRC has a wonderful guide on what are some of our first steps. Even for academic institutions, you'll notice on both mine and Steve's email bylines, we have our chosen pronouns and the pronouns that we use, putting those on name badge. Some of those tips are available for people, and you can start taking small steps, which then hopefully will just turn into bigger changes that we need to make across the board.
That's great. So my final question is, are there online resources, and I know you just shared a couple with us, but are there online resources or educational avenues that clinicians can use to learn more about how to communicate appropriately with patients in the LGBTQ community? I know you touched on just kind of overall training resources, but more specifically getting at the communication aspect, I think that perhaps that might be an area where many clinicians feel like they want to learn more about this. What is the most appropriate way to communicate with their patients and making sure that they're addressing all of their patients' concerns and that they're being sensitive and using the proper language? Do you have more to share on that?
Well, I think my first piece of advice is we have to remember that an individual's sexual orientation and gender identity is just one aspect of who they are, right? So we all have an intersectionality of identity. So heterosexual person, that's one part of who they are. Someone who is gay, that's just one part of who they are. So we have to be careful that we don't separate it out so much that we forget our basic communication skills. We need to engage with people who are members of the sexual and gender minority population, just like we would anyone else. We want to treat them with the same respect, use the same kind of open-ending questions that we would anyone. I think sometimes by taking out that one identity and dissecting it can do more harm than good. Now, that being said, we do have a responsibility to keep up with affirming language.
Mm-hmm.
And how do we ask somebody their pronouns? How do I ask somebody what name they use? How do I ask somebody what their gender identity is? And so again, I refer you back to the National LGBTQIA Health Education Center. They have several publications that literally just gives you a list of all the terminology. So what does all of this mean? And then it also has a whole guide on how do you ask someone their chosen pronouns? And the answer to that is you ask them, right? But that might not seem obvious to people if they haven't, right? If they haven't specifically done this before. And we'll just step by step, we'll say, okay, now how do you ask this? What do you do if you're filling a prescription and the legal name doesn't match the chosen name? How do you handle that? That's all part of that communication piece. And I think then, like Steve mentioned, his program, the program that I run, opportunities to speak with your colleagues, networking, sharing some of your concerns, getting suggestions back, talking with other people about challenges that they've had. Steve and I learn a lot by just talking to each other.
Yes.
And I share with him challenges I've come up against in the clinical setting, shares experiences he's had. You always walk away with more information.
The Fenway resource that Rhonda was speaking of is very thorough. It's been developed over a long period of time, and it does speak directly to care providers. It's oriented towards you. And there's a lot in there, as Rhonda said, about communicating and the way to ask questions. And I think it's quite natural to be afraid of getting it wrong, right? You want to make sure you get it right. And they've got terrific resources there on suggestions on ways to ask things and make you feel more confident about your patient interaction.
That's great. So we will include a link to that in our show notes. I'd like to thank you so much for your time. And this was such an important, timely interview. And thank you for sharing such great information with us.
You are quite welcome. Thanks for having us.
You're welcome. Yes, thank you. Thank you for giving us the opportunity.
Thank you. This episode has been brought to you by the NEI Podcast. With nearly 100 episodes, you can find us on iTunes, iHeartRadio, Libsyn, and virtually any platform that you prefer to listen to podcasts. If you've enjoyed this episode, we ask that you kindly leave a review for us. Go to any of the platforms mentioned and leave a star rating or a comment. We'd love to hear from you.